Okay, so we've had some technical difficulties, and we're going to try to start up again. I'm going to let Dr. Trotman, Dr. Robin Trotman, talk to us a little bit today about virus spread, about new treatment options, about vaccines, and maybe some hope for the future and the holidays. So Dr. Trotman.
Good. So thanks. I hope everybody's hanging in there with us on this pause. I think this technical difficulties is representative of 2020 and what we're experiencing. But it is November, and we've been at this now for 9 months, and we've learned a lot. So I want to talk about some things we know about this virus and what's evolved and what's changed in the last 9 months. We've learned to be very humble in our science, and we really ask that people have grace and understand the evolving dynamic nature of identifying a pathogen in December and coming up with a treatment by November. That is typically a 10 to 20 year process, and we've condensed that down into maybe 9 to 12 months. So this is incredibly rapid evolution of science, and when you do evolve that quickly, you really have to be humble and understand there's going to be changes in what we may think is dogma today. In the months to come, we may pivot. But we do have some fundamentals about which we're certain. And so here are the things that I'm certain about. I know the virus is transmitted from person to person. I know it's transmitted probably at a range or a radius of maybe 6 to 8 feet. If you cough, if you sneeze, you can potentially expel the droplet particles over a longer distance. We know that the non-pharmacologic interventions, those are the words that we use for things like physical distancing and wearing masks and hand hygiene. We know that those things work. We have empirical evidence. We have policies in our hospital that are informed by literature, evidence, and our own exposure history. We have 12,000 employees. We have employees that get sick, and we do tracings in the hospital. And one thing that we know is that if you are wearing a mask and in the setting of the hospital, eye protection, and you're exposed to someone known to have COVID-19, those healthcare workers typically don't get sick. I couple those experiences that we've had with real life patients and real life healthcare workers, and I couple that with the body of the literature, and I can tell you with certainty that facial coverings, when worn appropriately, and physical distancing, and in the setting of prolonged close contact, we use eye covering. That prevents transmission of this disease. And we know this because of all of the exposures that we've had. So those are things that we've learned. In February, I would have told you we don't want all citizens to wear masks because we didn't have enough of these medical masks for our healthcare workers. And we did not know at that time that people could transmit COVID-19 without symptoms. Now what we know is that maybe 60% of people have either minimal or no symptoms at all, especially young people. And we didn't know that those people would be able to transmit the virus. So those two variables, the fact that we were in a short supply and we were concerned about facial coverings and masks for healthcare workers. We saw the video from China, we saw the video from Italy, and that was our first concern, was our stuff, our supplies to protect our healthcare workers. So you couple that type of vulnerability for masks and the fact that we didn't know that this disease was so transmittable in asymptomatic people. You put those two together, and that's really what's informed our pivot. So when people ask, well, why did you tell us not to wear masks and now you do? It's because the science has evolved. It's informed what we do, and we're trying our best to be not dogmatic. We're trying to not lock into any type of science and to any facts and be open-minded and watch as the evidence evolves. And as it does, we know that in a closed room, inside of 6 feet, there's going to be a fraction of people that have the disease, and you are at risk for getting infected if you don't do those things. If you're outside and you're 6 to 8 feet away from somebody, they're not going to transmit disease to you. So I want people to think about the inside environment, the close proximity, the ability to reach out and touch someone. That's sort of your radius that you want to think about where people were infectious. And I can tell you in our community here, there might be as high as 2 to 3% of the people walking around in the community that are infected with COVID-19 and they don't even know it. So that's something that you have to be mindful of. I don't worry so much about walking through a grocery store. You know, you have to remember in February we were concerned about going to a grocery store. If everybody in the store is masked and we use the hand hygiene, you can safely get around the community. That's not what we're worried about. We're worried about 15 family members sitting in the basement watching college football. That's my dream. That's my kind of holiday, and that can't happen for me personally this year. I really do worry about gatherings of families that aren't in the same bubble. If you have a bubble of family members, if you have your core family that you're with day to day, those are the people you can really have close contact with, you can eat with, you can enjoy the holidays. But looking at the holidays going forward, I do worry about college students coming from out of town, elderly grandparents coming from out of town, and we mix all those people knowing that maybe 2 to 3% of those people are infected and don't know it. And you mix all those people in a house and watch games and do the dishes and make dinner, and that's a recipe for one of these super spreader events that you've read about or heard about. So right now, where the science is we have adequate testing. We know how to identify this virus. We don't know how to identify patients that aren't infected or that aren't symptomatic, and that's really what is spreading this disease. We're beyond the ability to hold back on this disease through our original strategy, which is testing, identification, isolating those people, and then doing contact tracings. That was our initial strategy, but we have far too many cases for that right now. So it's really incumbent on citizens to take their own personal responsibility for themselves and for their families, and to really control your ecosystem. We've talked about traveling. It is safe to travel right now. It's the destination that worries me. It's safe to go into a gas station and use the restroom. You're going to use hand hygiene, you're going to wear masks, and you're going to be mindful of the people around you, and you're going to try to separate yourself in time and space from unknown people. You're going to travel with your core group of family. If you have a family of 4, you're going to ride together. But it's that destination on the other end, and we've talked about some of those pointers. So I think that we know how the virus is transmitted. We just have to get people to really buy in to the evidence and the science and understand that there's a really high prevalence in our communities right now, and we all have to take responsibility. Right now, we have a vaccine. We have 2 vaccine candidates that are in the pipeline that look very promising. I've been reading and listening to the thought leaders on this topic, and I'm encouraged. These are called messenger RNA vaccines, so they're a little piece of the viral genetic material put into a particle and then given into the muscle. And the hope is that the body will find that piece of genetic material and make little pieces of the outside of the virus that our immune systems will recognize, and then that will give us protection over time. And they seem to be effective. The preliminary data on these look very promising with not a lot of side effects. So I'm very encouraged about the early safety data, but you really need about a 3-month look at vaccines to know that we're going to have safe. Most of the adverse events with the other vaccines that have come out over time, we saw those within the first 3 or 4 months. So I do expect the majority of serious adverse events related to the vaccines, those should be identified within the first 3 or 4 months. So by the time the vaccine is rolled out to the general population, we'll have ample safety data. As far as therapeutics go, I think that we're learning a lot. We're using a lot of strategies in the hospital today that we weren't using in March, April, May. For instance, we're really trying to avoid a breathing tube and a mechanical ventilator on patients. And what we know is we deliver oxygen through different techniques. We try to use different positioning of the patients, and we're having better outcomes than, say, the folks did in Europe early on. We have some therapeutic changes. We have very good data on dexamethasone that actually improves the survival of certain groups of patients. It doesn't work for patients that are at home and maybe not requiring oxygen. Dexamethasone is a steroid that probably blunts our immune system a little bit, and it helps slow down that inflammatory response to the virus. And so we use that for people who are in the hospital requiring oxygen. We use remdesivir, which is an antiviral medicine. It's found to be safe. We have hundreds and hundreds of patient experiences with this. It's not a one-size-fits-all antiviral. It probably works if you give it early. And then coming down the pipeline, we have some other strategies. actually giving what's called passive immunization, giving people antibodies to the virus. So you've heard about monoclonal antibodies and you've heard about Regeneron. Those are compounds made in a lab that will mimic your own antibody response or your own immune response to the virus. So we have those medications coming down in the pipeline. Those will be used for people before they come into the hospital. So people who are at risk for having adverse outcomes with COVID-19, we might give them one of these therapies to help jumpstart their immune system so that they don't deteriorate and end up in the hospital. So that's the monoclonal antibody category. We also have several other studies that we're looking at where we will be enrolling patients in clinical trials on hyperimmune globulins. So we use what's called convalescent plasma. You've heard about that. So people who've had COVID have those immune antibodies in their blood. And we have patients donate, once they get better, once their illness is resolved, they donate their plasma, we take those antibodies out, and we give them to patients that are sick. Now, of that plasma that people donate, there's a fraction that is COVID antibodies or immune chemicals. Hyperimmune globulin would actually take those out and extract those in a concentrated form and give those to patients. So those are the strategies that we're using. We're using blood thinners with a sort of a risk stratification, and we're having much better outcomes. So if you come into the hospital in November of 2020 in the United States, your outcome will be better than it would have been in, say, March, just based on the evolution of the science, the strategies, and all of the equipment that we have today. So these things all together give me hope. We can take care of sick people in the hospital. We know how to do that. Right now we have too many people in the hospital. We are now at a level that we all feel comfortable managing. I did not think we could have 150 patients in our healthcare system with this virus, but we're doing it, we're managing it. We have incredible healthcare workers taking care of these patients. They're struggling with the humanity of this. They're struggling with the social discord that's going on around this. They come in and they work 12 to 13 hours and they leave and they hear the things that we're all hearing, and they're struggling. Mental health is a real issue within our community and within our work staff. The alienation of the patients, the isolation, plus the stress of the healthcare workers. So right now the situation is stable. We're able to manage what we have, but the supply chain of all of the equipment that we use, that makes me nervous. The welfare of our healthcare workers, that makes me incredibly nervous. And the things that we can do is, as a community, the things we can do are to really buckle down. And again, I go back to this hope that I have, and I see us having vaccine candidates that are going to be effective and safe by the summer. So I hope people can see this light at the end of the tunnel. There is hope. We're finding creative ways to move people about the healthcare system. I see hope in our therapeutics. I see hope in our outcomes. I'm hoping that I can see our community and our society coalesce with a sense of unity. I don't think we have to be divided about this. I think humanity trumps. Humanity is more important than, say, your political position right now. And so I'm hoping that people will coalesce over the coming months. We have the vaccine strategy, and we can all just buckle down and really dig in for the next few months. And I think by the summer, things are going to look a lot different. I think we'll still be battling with this virus, but I think that we'll have enough experience, enough drugs, enough of our supplies, and some degree of immunity out in the population. So I think that's my status update for now, and I'll leave it there.
Okay, thank you, Dr. Trotman. He's going to stay with us to help us answer questions in the end. I'm going to give you a little bit update of what our numbers look like, what our capacity looks like, things we're doing as a system to try to be better prepared to care for our community. Dr. Trotman mentioned we're hovering around 54 patients today in our system. The majority of those, about 123 or more, are at Cox South. We do have more patients in our rural hospitals in our system, and that's relieving pressure in Springfield. It's also patients that we know to be less acute and less likely to grow acute. We've now treated approaching 1,600 patients with this disease, and our physicians better understand what patients may turn, what patients may get sick quickly. So we're able to offload some of that responsibility to our other hospitals, and we're grateful for that. You may have heard some experts kind of project what we expect this winter to be like, and it's heading into the winter we feared. We need to be aware of that and be prepared for that. One thought is that we were about 8 or 9 months into this. Maybe as many as 15% of the country has got this virus at one point. And some predictions say that maybe another 15% will get this virus in the next 2.5 months. And so that seems manageable until you realize what it does to a hospital to have 9 months of patients spread out only in 2.5 months. So that means our volume's going to go up rapidly. So I want to tell you some things that we're doing to try to prepare for that. In total, within 2 weeks, we will have added 147 beds at Cox South. I have not heard of any other system be able to do that rapidly. J.E. Dunn has been our lead contractor. Right now, they've got a team working 7 days a week. They're going to take Thanksgiving Day off only to facilitate this. So they originally helped us build the 51-bed ICU, which is full, both of ICU and non-ICU patients, all COVID patients. We have added a 24-bed cardiac area that's off, giving us more capacity. And we're about to complete a 36-bed unit in that same tower at Cox South. We've also designed that unit to be able to be semi-private, so you could actually double it to 72 beds. So that adds 147 beds. Beds add very little value without nurses, and nursery therapists, and doctors. We've been very supported by our board in getting more nurses in, more traveling nurses. We're getting about 20 a weekend right now. And what has been fantastic about this group of traveling nurses is most of them are experienced with COVID. And so they've gone around the nation to hot spots. It's a premium to pay for this. Not every hospital can afford it. I'm grateful that our board of directors have given us the support that we can run off reserves to afford to get the care we need for our community. So what this really means is that November, December, and into January will be our darkest months. We're as prepared as we can be at this point. It also means that we're not long away from a spring and from vaccine that begins to be administered more broadly. A great sense of relief for me will come when that vaccine is administered to our frontline healthcare workers. They're the ones I'm most concerned about because without them, we can't take care of our community. And at the same time, we want the most vulnerable in our community to be vaccinated soon and early. And that will be helpful as well and help us look toward a reality that makes life more like what it used to be. What this may mean right now to the system is that we have times where Cox or Mercy are full and we go on diversion. And we're one of the rare communities that has made this agreement that we both can't go on diversion because there's really only 2 tertiary systems in Springfield. So if Mercy goes on diversion, what likely happens is those patients that would have gone there start coming to Cox, and we quickly fill up, and we have to be on diversion. And so instead of us both being on diversion, we're on what we call forced open. And what that means is that we will take our own ambulances, we'll take walk-ins. We are not able to take transfers from other hospitals. And so that leaves rural hospitals struggling even further to try to find a place. And we heard episodes last week of one case where a patient actually needed neurosurgery, and they looked for the appropriate bed, and they couldn't find one, and they went to Omaha and Tulsa and Little Rock and Memphis and St. Louis and Kansas City, and finally found one in Iowa. Took a fixed-wing flight to Iowa. Great outcome. The patient did very well, but they were within 30 minutes of maybe having a really bad outcome. It's a reminder that it's on us, our behavior, to protect each other, protect ourselves, so that we can avoid the spread continuing, and so our doctors and hospitals and nurses can manage this. We're getting a new CT technology, which is really kind of fascinating. I'm not sure if any other unit has a portable CT in a COVID ICU. Our pulmonologists thought that would be helpful to keep our patients safer. You might have an example where you may not know whether or not a patient's having a stroke or had a stroke, and to move that patient through the hospital is high risk for that patient and even for our staff. So that technology will be up and running soon. We've expanded our testing capability. We are still seeing very high symptomatic positivity rates. So we are hovering around 35% positive. So these are patients that have symptoms. And I believe right now in California, the metric to shut down is around 5 to 10%. and we're probably about 5 times higher right now. So that's not the approach that our state has chosen to take, which means that we are going to deal with more and more patients, but it doesn't mean we can't individually take responsibility. And as Dr. Trotman said about Thanksgiving, all great advice. One piece of advice I'd give all of us about Thanksgiving is you don't have to have Thanksgiving on Thanksgiving Day, right? If you want to be with your parents, your grandparents, there's no reason we can't celebrate Thanksgiving after a vaccine is out there and celebrate it in April or March. At the same time, I think we celebrate in our family bubbles. And my family, we will go to my mom's house and in her driveway, we'll eat dessert. And maybe we all take a family walk together outside, safe. So the important part of Thanksgiving is being together, and there's ways to be together, and hopefully the weather can help us be safer, and it doesn't have to be this next Thursday. I think Thanksgiving can be any time you want it to be. There are some misconceptions people have asked me to address. That I think we've passed a lot of that, but I'm going to try to address some of those. And a lot of them are about this motivation that hospitals are making a lot of money off COVID patients, and doctors are making a lot of money off COVID patients, and there's a lot of patients that we're saying have died related to COVID, and they haven't. And I want to kind of clear up what my understanding of that is. So the big picture for Cox Health, we had a 1% margin last year. Our fiscal year ended September 30th, so the majority of the time we've been under this pandemic. And to give you a reference point, that means for every dollar that we take in, we make a penny. We made a penny this year. So we did break even. I'm encouraged by that. We have lost money since the pandemic. So in the big picture, systems aren't making lots of money off of this. And again, I'm grateful that our board allowed us to go deep into reserves during the worst part of this to keep our operation going, to keep our employees employed and keep our staff going, and to reinvest in more staff. How hospitals are paid for a COVID patient might be interesting and to address some of the concerns. Generally, most of our payment comes from Medicare for this age group, and they pay on a prospective payment. It's a fixed sum by diagnosis. So no matter how long a patient's in the hospital, for example, if they have pneumonia and they're in a hospital 4 days or 40 days, we get a fixed sum. And so for COVID, many of our COVID patients fall into pneumonia category because it's a virus that's affecting major organ and affecting our lungs. And so just to give you a reference point, the government said if that patient tests positive for the PCR confirmed test, the reimbursement will go up 20%. And so what that means for a pneumonia case that's got acute respiratory distress associated with it, the hospital gets about $14,000. So if a patient is on a ventilator and in the hospital for 25 days, we get $14,000. If they need convalescent plasma and remdesivir, that's $3,000 to $6,000 just for that drug cost. So the fact of the matter is hospitals aren't profiting off of this. At the same time, it's not our goal to profit. It's our goal to have enough money to reinvest next year in the future, new capital and new support for our employees. Doctors, I've heard rumors that doctors get paid more when they say a patient died of COVID. Absolutely not true. And doctors are paid on the system that Medicare created that has to do with their sense of the relative amount of resources and time and expertise it takes to take care of certain types of patients. And so the fact of the matter is the most involved doctors right now in COVID are intensivists, pulmonologists, hospitalists, and infectious disease doctors. And I can tell you that in general, the way they're paid, they are generally making far less today than they did before the crisis, even though they're working longer and harder hours. And that's because the way the reimbursement is set, it's based on a visit of a patient. So you visit a patient once in the hospital, you have a certain level code, you apply, and that visit's not just one quick visit. We've got a team sitting in that ICU. Sometimes there might be 6 staff around one patient who's in crisis. And so that's just not true. And when you see these physicians understand they're working harder than ever, they're putting themselves in harm's way, and the reimbursement mechanism doesn't favor them. And so that's sort of how the reimbursement works for those that asked. And then the last thing, and Dr. Trotman may weigh in on this even better, is this question about death certificates and this idea that maybe only 6% of the patients died of COVID. And so let me give you my basic understanding of how death certificates work and how this virus works. Almost every virus attacks us by undermining a major organ in our body. So COVID, we most often think of the lung. So we think of pneumonia, we think of acute respiratory distress or adult respiratory distress syndrome, we think of heart issues, another major organ. So when you fill out a death certificate, you fill out the proximal cause, the most immediate cause of death. So when we have someone that gets COVID, that turns into pneumonia, that turns into adult acute respiratory distress, and they die from that, they died from that pneumonia and that respiratory distress. It caused by COVID, but if you fill out the death certificate, it should say proximal cause. And so it might be lung or heart disease, for example. Quite frankly, those that filled out, 6% due to COVID just filled it out wrong. And that was probably in a hurry and they didn't understand the rules at the time. So we can tell you that in our hospital, we have now lost, I think, 174 patients at Cox South to this disease. And they are patients that, with maybe one or two exceptions, would not have died otherwise. Some of them had underlying conditions. Most of us do. We remind you that underlying condition might be hypertension or pre-diabetic. Lifestyle things, obesity are all factors that contribute. And if you look in that room, our ICUs, you'll see there's a lot of patients that are suffering from these challenges. And the disease has moved to be a little bit heavier toward men as well. And so we're seeing a higher number of male patients. Early on, I think we saw more female patients because nursing homes were hit. And the nursing home populations tend to have more women because women live longer. And so that's kind of changed things a little bit. But we're seeing younger patients. The youngest patient we've lost to this disease was 31. And at the same time, we've had someone over 100 years old walk out of this hospital with the disease fine. And so it has a randomness to it that is difficult for us to grasp sometimes. Those are some of the main points I think we wanted to cover. And I'm looking around to see if we have questions coming. And Caitlin McConnell's there, and she's saying yes. So let's hear some questions.
Yeah, we have some. They're kind of in a little bit of different categories, so I'll try to categorize a little bit. But the first one, we had a picture that was shared yesterday about kind of a comparison between the ICU a few months ago after it was done and recently. And it's maybe more for Dr. Trotman, although Steve, I know you've been in there as well. But for people, most of the people in the world don't see what this reality actually looks like. And can you kind of just explain to them really, at a detailed level, like when you go in there, what is it like and why is it, what is so awful about it?
Well, it's a mixed blessing. So let me tell you about the ICU and 50 beds and a team of staff that have been up there all day, and that the staff that work in there have been instrumental in building what we have. I mean, it is real-time, day-to-day feedback. I won't mention names, but we have a few nurse leaders that this is all they do is try to streamline what used to be open construction with external pipe and storage, which now is a state-of-the-art ICU. So the staff in there have coalesced like nothing I've seen. It's equivalent to a team. I wasn't in the military. I would say it's probably something like that. And they're on. They're on. So when they show up at 7 a.m., they are engaged, and it's all day in the PPE. We wear. They're mostly wearing the bunny suit, so it's a full coverall suit, either an N95 mask or a respirator, and then a face shield. And it's not comfortable. We're doing the best we can with what we have, but I can tell you that the staff remain upbeat when their shift is on. They're struggling with families. They're struggling to give bad news to family members over the phone. That's probably the most taxing thing that we see, is the inability to have family and loved ones in that ICU experiencing this with their loved one, to be able to just see and to touch. That's probably the biggest struggle. But when you go in there, it is often controlled chaos. So I came there before I came here, and I have an incredible amount of respect and confidence in that crew. They make this look easy, and it's not easy. It is controlled chaos. But through experience, through time, through these folks working together and administration adopting whatever needs to be done real time. These are real-time changes. It's pretty smooth. We have episodes. We had 3 codes at one time the other day, and we lose patients. And staff struggle, and we have infrastructure we're working on that to try to help support the mental health of the staff. The patients that leave there, I can tell you, I personally have a patient that I've taken care of for 10 years, and he cries every day because he's so grateful. And he's seen, he was awake, he wasn't intubated, and he saw what was going on in the unit for about 8 days. And he was traumatized and moved. And personally, he's calling my office wanting to know, what can I do? Because he understands the situation there. It's safe. The staff aren't getting sick. In fact, if you look at the staff that work in that unit, they probably have a lower incidence of having COVID infections than the rest of our staff. And that's probably because of the strict adherence to the PPE and then their insight and their caution that they take in the community. So they leave there with a hyper sense of awareness of the gravity of this. So right now we have everything we need in there. We don't have a lot of space. What space we do have is really going to be most vulnerable by the staff that we need to take care of patients in those beds. You have to remember, it takes one nurse for 2 patients in the ICU. On a general medical floor, we might have 6 patients for 1 nurse, but on our COVID floors, it's probably triple that because we have to have people helping run supplies and watch the PPE. We want to make sure that people put it on safely. So that's a little snapshot of the West Tower ICU. But again, it is a credit to the people that work in there, the therapists. I have to give credit to the pharmacists too. I mean, a pharmacist would never have thought they would be wearing a respirator and PPE and having to go around and take care of these patients. But I mean, it's a team. This team moves together, the therapist, the charge nurse, the pharmacist, and the aides, and they just go from patient to patient and make it through the unit. So it's a pretty impressive process to think what we've evolved in the last 5 months of doing this in this tower.
The next one, I'll kind of jump over to Steve, and Steve kind of talked on this a little bit, but especially with regarding the number of patients we're seeing now. How does this, if it does at all, impact our ability to give care for other issues, and what concerns should people be aware of?
Yeah, so I want to give a reference point. So early in the CARES Act funding, the government defined what a surge hospital was, and this is early in the spring, and if they had 160 total COVID patients, it was considered a surge. We've now about to surpass 1,600, so 10 times more. We've had time that allowed us to be more prepared. So we see the case fatality rate, our mortality rate going down compared to what New York saw early on, and there's many reasons for that. But we shouldn't minimize that this disease is very risky. Right now, the mortality rate looks better than I think it will end up because we know there's a delayed shadow effect to new cases, and so we're starting to see mortality go up, so that's worrisome. What we saw in New York, for example, so that's an example of hospitals completely overwhelmed, 40% mortality rate. Right now it's running about 10 to 15%, so that tells you right off the bat that the ability to manage these patients is compromised by volume when you don't have the same staffing ratios, and it also means you could compromise the quality of care for other patients as we're all stretched. So. And then the other point I want to make is I heard from one person that say, my father has a need for CT, and I think I'll just wait because I don't want to overburden the system. So what's really important for us is that we take care of everyone, not just COVID patients. At any given time, we have as many cardiac or stroke or oncology patients. And so if you have a routine exam to be done, I will guarantee you that you are far safer in the walls of a hospital right now with universal 100% protection going on than about any other setting you'd be. Certainly more safe than a large family gathering at Thanksgiving. So I do want to encourage people, if you've got routine testing that needs to be done to identify what's going on, we want to take care of you. And so we want to focus on that. The data just shows that as hospital volumes go up across the world, mortality rises and quality goes down. So it's another reason why we're encouraging our community and others to take action to keep themselves safe so we can manage that volume.
And Caitlin, I'll lean in on that one too. That's an active process. I mean, we have a committee of doctors and leaders working every day to make sure that our non-COVID related procedures are being optimized. Are we doing the most that we can with the most urgent procedures, and how do we make sure that those continue to run in the system that is slowly being encroached on by COVID? So it's an active process looking how to keep those medically necessary procedures and tests being addressed as quickly as possible. That's a couple committees, that's a every couple day meeting process to keep those folks in mind. But again, what Mr. Edwards says is true. I think it's safer for you to come into the hospital for your medically necessary procedure probably than it is to be in certain areas of our community right now.
Back to you, Dr. Trotman. You mentioned kind of the scene of the ICU and how hectic and the controlled chaos that it is. How are family members and people that your staff have to deal with in the ICU able to help connect with families of patients and help them understand what's going on? How does that process work? And then, off of that, do the staff still find people who might not believe this is real? And if they do, what is there something that we all can help educate people about to help spread the awareness around this?
Yeah, so we're using technology mostly for the communication. I know the nurses every day call the family, give the updates. The doctors try to do it every day. I go into the ICU and try to offload some of the calls from the intensivists because it really is hard to make 25 family phone calls. And people really need and deserve to have that feedback from the nurse and the doctor. So we use FaceTime or whatever video conferencing that we can use. And then people do move in the hospital, they move out of isolation. So once they're out of their either 10 or 20-day isolation period, we have visiting hours in the hospital. So eventually that can happen. But yeah, we do struggle, especially tough decisions. And there are very, very rare exceptions where you need family around to help walk through a tough decision. And so we're sort of learning as we go what are the high-risk exposures for family. But yeah, that's a tough one. It's all through technology and just good open dialogue communication to ensure that everybody's up to speed and understands the progress of their loved one. And yes, we do have family that still have hesitancy and uncertainty about the reality of this. And what I can tell you is with 100% certainty, we're all going to be touched by this soon. We're all going to have a loved one, an acquaintance who's going to be sick, hopefully not succumb to this, and it's going to touch all of us. We're going to have, even if you don't have somebody that's sick in your family, the people you rely on in your community for childcare or for education. These things are going to touch all of us. So it's inescapable. It's a reality that we can't deny, and it's just through open dialogue. And I tell the nurses, try to understand what is the barrier to that family member not understanding that. We've had patients leave the hospital and throw the mask at the nurse and say, I'm not wearing this because this is fake. That's unfortunate. But really, the question is, why do they feel this way? Why do they think this? What is the hesitancy? And then maybe address the fundamentals. So if they have reluctance and hesitancy, it might be fear, it might be uncertainty, it might be concern for their loved ones. And so I just ask that people really explore those questions and just have an open dialogue. And that's about the best we can do now. But we're all going to be touched by this. Nobody's going to be able to escape this in the coming months.
There were a couple questions that are sort of in the data, maybe evolving situations with regard to information around COVID that I'll kind of lump together here. But, what is the likelihood at this point that we think people can get reoccurrence of COVID? How long after testing positive will someone remain to test positive? And are we thinking at this point with the vaccine that it will be an annual thing like the flu, or is it that still evolving?
That is a wealth of nuanced, very tough scientific questions. But the first one is reinfection. And yes, people are becoming reinfected. We've had a case of reinfection that was very clear. You can't use the PCR test to define a reinfection if it's in a certain window. So the PCR test that we use, the nose swab, the painful nose swab, that test looks for the genetic material of the virus. And there are still little pieces of genetic material in your white blood cells and the lymph tissue in your nose and your throat, but it doesn't mean there's active live virus. So we know that at about 10 days to 2 weeks, not very many people are still shedding active infectious virus that can transmit, but their test remains positive. There's reports of people having a positive test for 90 days. So all that means is that there's little parts of the virus in your white blood cells and in your throat. It's akin to there being tires or mufflers for a car, but there's not an engine in a mobile car. So we can detect those little pieces out for a long time. There have been very rare, not common cases of people being infected, resolving, developing antibodies, having negative tests, having a period of being healthy and well, and then becoming infected again. So that happens, but it's rare. The thought, the vaccines are going to need to be boosted. It's not the mRNA vaccines are going to need a couple doses, and that's coming soon. We do know that when you give multiple dose vaccines, the second and the third dose are more challenging to get people back into healthcare. So first of all, know that there's a good chance that for your COVID vaccine, you'll need 2 doses. Will this be a virus vaccine that's given every year? That's a nebulous question. Maybe not. Let's see how this works. We really don't have a good correlate or surrogate for protection. So just because you have an antibody test that's positive, that doesn't mean you can't get infected. And just because you don't have an antibody, that doesn't mean you're not protected. We know that we really worry about the function of the antibody levels. And we also know there's other parts of the immune system that protect you. So even when we do these tests on the vaccine and we say these people have antibodies, we don't know how durable they are, how long they last, and we don't know if those are actually the marker of long-term protection. So there's too many questions right now left in the science. I mean, we only have a couple months of data on these vaccines. So I don't anticipate that this would be an annual vaccine, but the technology of the mRNA vaccine is very different than the flu vaccine, which is a chicken and an egg and a dose, right? So that takes time to manufacture. This is a genetic material RNA vaccine, and it can be manufactured more quickly. So if we do end up needing vaccines, once we have the technology and the safety data, it'll be easier to deploy that annually.
Is it looking like people who have had COVID can also be vaccinated?
I haven't seen these studies, these last studies that we're talking about haven't been published. The original studies, I think that was an exclusion. So we won't know what will happen when we roll this out to the general population. But those patients weren't included in the phase 2 studies, which is what we're looking at. And then these studies are still enrolling right now.
I think the one other thing, and I'd ask for both of you if you have comments, both of you have been in healthcare for a long time, you've seen a lot of different flu seasons, and we keep hearing that this is the flu, it's no different than the flu. From, what would you say to explain why this is different than the flu, both from a science perspective and also just what we see with flu numbers every year? How is this, what's different?
Steve's our medical historian who's been reading curiously about different influenza pandemics, so you take a shot first.
Well, I think we can look at, flu's can be very dangerous, right, and very deadly, and the Spanish flu is a great example of maybe our dead list in the last over 100 years. This doesn't model flu other than it's respiratory, which means we seem to have these patterns where respiratory viruses tend to get increased in the fall, winter months. That's probably the very nature of them. It's probably because humidity is lower. It's probably because there's less UV light. It's probably because we're congregating together. And even as our body dries out, we might be more susceptible. So it's followed that pattern, except scarily, it didn't die off in the summer months. So it kept rising. And so we thought we might have a respite in the summer. As a matter of fact, we heated up. I think you just have to look at the difference in the long haul effect of it. We know this is attacking all kinds of organs in the body. I believe we'll find mental health issues associated with not just the stress, but the effect on the brain as well. We saw that with the Spanish flu. We will see every major organ, a possibility of being affected by it. The patients that we know have had viruses, viruses can stay in your system and cause problems decades later. And that's what's scary about this. I think of chickenpox, I think of shingles, what could happen. One of the smartest physicians I know, who's very grounded, said, it's on a long list of things I don't want to have. And, you don't run out of oxygen at hospitals. You don't have 250,000 deaths in the flu. We've not had that kind of flu season. Most predict that we may have 400,000 to 500,000 deaths in the United States by the time this is over. So that's not a normal flu. We typically have about 18 to 28 additional patients in the hospital in flu season associated with flu. We don't have 150. And so it's got a bigger R naught, so it spreads faster. than many flus, and it's got an elevated mortality that's 5 to 10 times higher probably. Those people that say, hey, 99% of people survive, that's great. And if that was true, that means that 3.3 million Americans die. And I remind anyone, if you speak that way and you comment on social media, know there's someone watching those comments that lost a loved one. And as Dr. Fauci said, I don't know how to tell you to care. And so I ask people to be very careful. But this is different. Dr. Trotman has been dealing with this and knows it much better than I do. But it's different than any flu we've ever had. It's a coronavirus. It's structurally different.
Yeah, all of those. I think that the other key that I would add is mortality rate, and Steve hinted at this. It's not the only metric that we use to assess the severity of this disease. We don't look at severity of car wrecks and the utility of seatbelts as just saving lives. People are injured and their lives are changed, so we wear seatbelts for many, many reasons other than just to save lives. So mortality is not the only metric by which an infectious disease should be defined. If you play a sport and you want to play the sport, your sport is going to be affected. Your lifestyle is going to be affected. I mean, I take the most non-health related aspect of your life that you can imagine, and that too is going to be affected. General health is being affected, and we have patients that have been on oxygen for 3 months. We've had patients with heart failure and patients on dialysis, and they survived. So there are lots of outcomes that from this virus that are not just mortality, that really affect humanity, and the mental health is, I mean, that's unquantifiable. I don't even know how to put a number on that, but that's something we consider. The numbers make this different than influenza. Just the deaths across the United States. If you just use that metric, you can see this. We're already at, 4 to 5 times, at least 3 to 4 times a normal influenza season. Here's the big difference in this virus that's with influenza is this asymptomatic transmission, and that's what really makes this so curious. Is we didn't know this 9 months ago that so many asymptomatic people could spread this disease. And so that makes influenza a little different. Another big thing to think about is think about the host. You've had influenza in the past, you have a repertoire of antibodies, you've had vaccines every year. So you have this immune system that is not naive to this. Our immune system is a little bit more naive to this virus. And so you have some memory in there in your immune system for influenza. It probably makes the reaction differently. We have very good treatments for influenza. Oseltamivir and some of these drugs work. So when people ask me what's the difference, I'd say, well, you've been vaccinated and you had influenza before, and we have treatments. We had a surplus of testing at the outset of every flu season. We weren't struggling to have 4-day turnaround for testing. And then the long haul symptoms. And then the other thing is we know what correlates with immunity in influenza. We use something called geometric mean titers. So we know antibody levels and we know efficacy of vaccines. In this case, we don't really even know what part of your immune system gives you 100% protection. So a lot of those questions, a lot of that uncertainty is what distinguishes this from influenza in my mind.
I got something to conclude with. I might just say that, I feel very privileged. We have an incident command team, and it is led by the smartest people I know. And I'm privileged to often be their voice, as is Dr. Trotman. And oftentimes people question, they see a meme on Facebook, and therefore, and let me tell you when we speak, this is who we're representing. So on our incident command team, we have a leading ER physician who trained at WashU and Mayo Clinic. We have a pulmonologist intensivist that trained at Yale and Cleveland Clinic. Dr. Trotman trained at Wake Forest, which in infectious disease is among the very best in the world. We have a hospitalist that's also Cleveland Clinic trained. These are the facilities and academic programs that 1% of the very smartest get into, and they're leading our program. So when we speak to you, we're speaking as a combined voice. And when I think of some of these people, it also reminds me how grateful I am by the people we're surrounded by. So that Yale-trained and Cleveland Clinic-trained intensivist is from Rogersville, Missouri, and he came back here and he's serving his community. So when he speaks on behalf of people he cares about. His family live here, his loved ones. At the same time, we have physicians that have traveled all over the world and have found this their home, and they're committing to this home to protect our community. they're not getting benefit from this. They're sacrificing from this, and they're the bravest people I know. And I'm really proud to be surrounded by those people that are serving our community. And again, when I speak, I'm merely the voice of some really, really gifted people who are too smart to be on camera.
I don't know that I would want to say anything after that. That I'll just mess that one up. But no, I would ask that people think about this as a humanity issue, not a political issue, not a polarizing issue, not an issue to generate discord in social media and in public venues. That's not the intention of any of this. Everything we do is altruistic and hopefully trying to inform. We know knowledge is key here, and if I would ask a favor, and that would just be trust, open-mindedness, and grace, and understand that the science is evolving. There remains many, many questions. And reach out to your local healthcare provider. It's not just about the nurses working in the COVID unit. If you know any of those people, order lunch for them, order dinner for them. They're struggling mightily. But all of the healthcare workers, the paramedics, all of these people are struggling with this. I just think about even a pediatric clinic where they're trying to do the best for their kids. They're not in the throes in the ICU tower, but all they're trying to do is make sure that their kids get tested and treated appropriately, and it's in the midst of this polarization and this lack of trust of science. So I would ask people to just give us a few more months, a little bit of grace, and reach out to your healthcare providers and just try to pep them up a little bit, because a lot of them are struggling right now.
So we want to say thanks for tuning in. This is a live event, and we had some hiccups early on, but it's also recorded, and it will be available as well. And so if you saw part of this and would like to see all of it, you can go through Facebook and our homepage to find it. We want to be very available for our community, and so we continue to try to answer questions. We need you to ask questions, because we think the more information out there, the better we can defeat this disease. And remind you, please be safe for the holidays, and this is a time especially not to take risk. We're almost through this. 3 more months of really hardship, and then I see sunshine and I see the spring coming. So thanks for tuning in, and we appreciate what you're doing in the community to keep us all safe as well.